be incorporating some image-based aspects. Along with that, the applied aspects, the possible, MCQs that come from those related concepts, right? So first and foremost, we'll be starting off with. Okay. तो कब करेंगे लाइव? मैंने स्टार्ट स्ट्रीम कर दिया। अच्छा अच्छा, वो सही टाइम पे बता दिया, वरना फिर से यही बकैती करनी पड़ी। बता देना जब वो लाइव हो जाए। हो गया? अरे hello, good evening, friends. So today we meet again yet on another Saturday evening, continuing with our series of, covering the most important MCQs in a short span of time, right? So about half an hour to 40-minute session. We'll keep it crisp. We'll be touching up on, touching on the most, you can say, important and slightly controversial MCQs, which are tough to kind of reach that correct answer. Many a times there are questions in which we exclude 2 out of the 4 options, but then we're slightly confused between 2 options, right? So we're going to be dwelling on that, guys. And the other important thing that I want to incorporate in today's evening session is these MCQs along with their related images and the possible applied MCQs that can come from these images, right? And of course the controversial aspects. So we are going to be covering all of that, right? So in endodontics, you just first thing that comes to mind in endodontics, working length determination, your access prep, your irrigation, your post endodontic restorations, so on and so forth, right? So one question that has been creating some problem with you guys has been, what is the most, predictable, or out of the given 4 options, what is the best answer in pointing out, or in, keeping as a landmark or as an anatomical landmark for working length determination, right? So the question is like, which of these is a predictable landmark for working length determination? I'll just write this down, the options like the C, E, J. So you have the CEJ, then you have the CDJ, all right? Then you have the, say, the radiographic apex, all right, guys? And then you have your apical constriction. Now, which one of these would be the most predictable landmark, right? Which you would, right at which point your cleaning and shaping and obturation procedures would stop, right, guys? Now, ideally speaking, from a histologic perspective, the answer should be CDJ. So many a times, if you have options which are absolutely unrelated to apical anatomy, like, for example, if the question was reframed as, the options were reframed as the CEJ, the CDJ, the gingiva, all right, and the alveolar bone, guys, then the option is straight away simple. The answer is CDJ. All right, the same question, the best landmark for deciding your working length, if the options were on the left hand side, right? CEJ, CDJ, radiographic apex, apical constriction. Where would you stop? Now in this, the best answer amongst the options here is your apical constriction, guys. Now I'll tell you why. Ideally, you should stop your cleaning and shaping procedures when your pulp tissue ends. Where does your pulp tissue ends ideally? That is, what do we mean by ideally? Histologically, right? That is your cemento-dentinal junction, right? So ideally speaking, if that's my root. That's my canal, guys. All right. Now let me just magnify this some more. Now what's going to happen is, all of you know that up to some distance inside the root canal, your cementum exists, right? So cementum is going to be existing up to some distance here along the entire cross section of your root canal. Now problem is, the problem clinically is that your cementum does not terminate at one particular cross section of the root canal, right? That's one particular cross sectional level of your root canal. That doesn't happen. However, your working length has to be one unique length, whether 20 mm, 21 mm, for one particular canal, right? But in one particular canal, the cementodentinal junction may vary. It may be, cementum might just go up the canal somewhere here at, say, the buccal wall, and might just be, more towards the external surface of the root on the, say, the mesial wall. So where do you stop? You have to stop at one particular mathematical point, which is the smallest cross-sectional diameter of the unprepared root canal, and that is your minor diameter, which is your apical constriction. Right, guys? So apical constriction would be what part of the canal? So this is my root canal, guys. That's my constriction, and that's the slight portion, that's the slight morning glory appearance between the apical constriction and the major diameter, right? So that's my apical constriction, and that's my major diameter, guys, right? And this kind of a, sun rising in between the hills, the diagram that we used to make when we were small kids, right? This is known as the morning glory appearance, right, guys? So if you have, out of the CEJ, CDJ, radiographic apex and apical constriction, then you have to have one particular point. You cannot vary along the cross section. Then your answer becomes, the best answer is apical constriction. If you don't have apical constriction in the options, then all the options are outrightly wrong. I mean, CEJ is right at the cervical end of the cervical, junction of the tooth. Then you have gingiva, alveolar bone, obviously not. Then obviously CDJ is a better answer. Right, guys? So I hope this concept is clear. Very, 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 I mean, you guys find it very confusing. So I just wanted to get this clear once and for all. Now the applied part. One more applied part, guys. You have an image like this, image-based question like this. You all know that's your apex locator. And more specifically, that's your root ZX apex locator. The third question that comes is, what is it used to determine? It is used to determine the working length. As simple as that. By which method? Electronic method. Okay, fine. Now the problem area. This level, this red zone, the zero reading, right where your green, blue and green markings end, and this what do you call, the red line here, right, which is corresponding to the apex here. What does this signify? That is the question that comes and is considered pretty you can say confusing by you guys. Now this represents what? Radiographic apex, apical foramen, apical constriction, right? That is the question that comes. So let us just frame this question here, write this down, and just solve this once and for all without any confusion. The zero reading, guys, the zero reading on the display of the apex locator represents what? Does it represent the apical constriction, or which is nothing but the minor diameter, right? Which is nothing but the apical stop. I'm just writing this synonyms here so that you don't get confused. I mean, the examiner can just pick up any term. Then, does it represent an area which is near, or your file is near your apical foramen? Right? Does the zero reading represents that you are way beyond the apical foramen, meaning you are in the periapical spaces, right? Or, an option can be that it is, the reading of the apex locator, the reading of the apex locators is unpredictable and, to generalize, inaccurate. All right, guys. Many people think who don't know the correct way of using the apex locator, oh, it's not good. It's as simple as that. They just reject it. It's not good. Doesn't work. Right? Anyways, now the question is, here, what is the confusion? Most of you are able to eliminate 3 and 4. You get confused between apical constriction and apical foramen. Now, guys, zero reading of the apex locator means that you are somewhere near the apical foramen. All right? Please remember this. You're somewhere near the apical foramen means you're somewhere basically, for all practical purposes, in the PDL tissues. Basically, you're just beyond the apical constriction, right? And more or less, your dentine pulp complex has stopped there. You're somewhere in the zone right at the apical foramen, or probably just short of it, but beyond the apical constriction. So again, you are surrounded by cementum. So basically, you are for all practical purposes, histologically, you are in the periapical tissues, right? So it represents the apical foramen, or somewhere very near to that. So what are you supposed to do? You're supposed to reduce, for your correct working length, you're supposed to reduce that length by 0.5 to 1 mm, so that you can say that according to my apex locator, my working length is this. And what is that length? That means that the zero reading, if your length was, with your reference point, was 20.5 mm, then your working length is 19.5 to 20 mm, which is 0.5 to 1 mm short of that length, right? So the correct answer here is, guys, apical foramen. This is a question that has been asked in your AIMS. A very important question, guys. All right. Next question, guys. If a patient is allergic to sodium hypochlorite, what other material could that patient be allergic to? Now, guys, sodium hypochlorite is what? Sodium hypochlorite. Right? So primarily, what does it have? Sodium and chlorine ions, which is, a part of, these are present as part of our normal physiology. These are normal electrolytes, potassium, sodium, chloride, right? That's what the human body is all about. Water, potassium, sodium, chloride, and blood, right? So first of all, another MCQ that comes here is, usually the reaction, the hypersensitivity or allergic reactions to sodium hypochlorite are rare. It is rare to find a person to be allergic to sodium hypochlorite. The reason, you can get an assertion and reasoning type of question here. So the assertion is this. The statement is, it's rare to find a person or people allergic to sodium hypochlorite. That's, of course, that assertion is true. The reason is, the correct reason is that sodium and chlorine are normal normal constituents of the human body. So obviously, it's very rare to have allergy to sodium hypochlorite solution. However, it's rare, but biology is a science of exceptions. So whenever you have a patient who is allergic to sodium hypochlorite, then anything that contains chlorine should not be used. So in such a case, do not irrigate with, of course, sodium hypochlorite. That's one, because you're allergic to that, but also not with, do not irrigate with, number one, sodium hypochlorite, but also not with chlorhexidine. Why? Because of its chlorine content, guys. Right? Next MCQ that comes, that the applied part that comes in relation to sodium hypochlorite and specifically chlorine. Usually, chlorine or the hypochlorous acid, HOCl, or the OCl ions, basically the chlorine component is the one which is providing sodium hypochlorite with its tissue dissolving and antibacterial properties, right? Now, what usually happens is that when sodium hypochlorite gets in contact with the organic tissue, starts to dissolve it, right? It causes proteolysis of the proteins, collagen of the organic tissue. Now, usually it gets depleted. It kind of gets, it does its work, and it gets depleted in about 2 minutes time. Now that's an important MCQ. That is a figure that is given in your Cohen. So 2 minutes time, the sodium hypochlorite, which is in contact with organic tissue, does its work and gets, you can say, depleted or inactivated or no longer effective, ineffective. So that's my statement, guys. That's my statement or assertion. Then that is true. Right? And what is the applied part here? That is the rationale. The rationale of continuously replenishing sodium hypochlorite during your BMP is this, that it gets deactivated or ineffective within 2 minutes. So if the examiner will rephrase it and he'll say that my assertion is that continuous replenishment of sodium hypochlorite is important during BMP or cleaning and shaping. Is this a true statement? It's true. What is the reason? That it gets depleted within a very short span of time, and that is 2 minutes. So if the examiner says 2 minutes, it's true. If the examiner says 10 minutes, 15 minutes, it's false. Right, guys? So that's the applied part that can come in your, advanced examinations like INI. Right? It can come as a simple part in your NEET examination, like, sodium hypochlorite gets, the chlorine component gets inactivated in 2 minutes, and so on and so forth. Right, guys? Great. What else? What else do we have? In relation to sodium hypochlorite and chlorhexidine. Since we're talking of both sodium hypochlorite and chlorhexidine, another image-based question, guys. What is this? This is an orange-colored precipitate. That is an image-based question that can come. Between what? Now here, there's a lot of confusion. Students get confused. Oh, what was it? Was it chlorhexidine and EDTA? What was it? Hypo and EDTA? Was it hypo and chlorhexidine? Right? So please remember, these kind of precipitate type questions, the starting point of your irrigation is not hypo, it's Chlorex. I'll tell you a mnemonic of remembering this. Chlorex, right? Just remember this. So when I start with Chlorex, now make a T here. Start with Chlorex. Make a T. Subdivisions. When it's mixed with hypo, then it forms an orange colored precipitate. Orange colored precipitate, which is para-chloroaniline, right? Or 4, which is the same as para position is the 4th position, right? Which is 4-chloroaniline. And this is considered to be mutagenic or carcinogenic to the human body, right? Now, if Chlorex is mixed with EDTA, it forms a white colored salt, which is as such not harmful, but it's just that it's tough to dissolve away, right? Which brings me to the next question, that if I am to use my chlorhexidine as a final rinse irrigant, which many clinicians prefer, especially in retreatment cases, because of the effect of substantivity of chlorhexidine, then if during my entire BMP protocol, I have been using hypo and EDTA and so on and so forth, then before the use of chlorhexidine, dry the canals with paper point so that neither hypo nor any remnants of EDTA are left behind in the root canal wall to react with Chlorex. So this brings me to the next important MCQ. When chlorhexidine is decided to be used as a final rinse irrigant, then dry the canal with paper points before irrigating with chlorhexidine. Is that fine, guys? Right? And the reason, you know, I don't want chlorhexidine to react with hypo, otherwise it would form para-chloroaniline, which is an orange colored precipitate, which is carcinogenic and toxic to the human body. I don't want it to be reacting with any remnant EDTA because it would form insoluble white colored salt or precipitate, which would be tough to remove, right? It would kind of stick to the wall of the root canal. So that's how, you know, these questions are interlinked, and that's how we should study. So all these are all important MCQs, guys. Right? Next important point, very important MCQ, not mentioned in your Cohen, only in your Engel, guys. What is the treatment of choice if your remaining radicular dentine thickness is 1 mm and the case requires a post and core? Basically, what he's saying is that you have a very compromised case. You know, you're because of caries, when you've removed all your caries, done all your filing, completed your BMP, you know, your coronal tooth structure, irrespective of its height, the thickness of the walls, buccal, lingual, mesial, distal walls, has been rendered very less. All right? Just about 1 mm. Then what kind of post and core system and what kind of preparation should you be doing? Now, this question has been answered only in Engel and not in Cohen. Right? Cohen has been very, has kind of not done justice to the topic of post and core, frankly. they have not divided the indications of, metal post versus fiber post. They've kind of clubbed everything together, right? So that's why I wanted to get this question here today, and again solve it once and for all, guys. This video is going to become a resource for you. Every time you're going to see it, you're going to remember this. So here, number one thing, the main important thing that is driving us towards the correct answer is that now I cannot afford more filing and more preparation of my root canal and my coronal tooth structure from inside the hollowness of my root canal. Why? Because my surrounding walls are already very thin. So if I take my H file and start to prepare a nice cross-sectional circular uniform cross-section of the root canal, which so as to prepare the canal to receive a proper, nice, well-fitting, prefabricated fiber post, I won't be left with any tooth structure. And you all know the success of any post-endodontic restoration. The most important thing is remaining healthy tooth structure. It's not the quality of the crown. It's not the post and core, the wonderful technique. You might be a great clinician, but if you don't have healthy tooth structure underneath, what are you going to do, guys? Right? You're not left with anything. So here, the answer is simple. Do no preparation. Are you asking no preparation? Meaning no preparation for the post? For the post space? No preparation. So you will have to incorporate all those irregularities of the canal, right? If it's say upper central incisor, the cross section of the canal is what? Triangular, and then there are some other irregularities here. Some portion of the canal is elliptical, kidney bean shaped. Incorporate all of that. The only thing that you have to do for the word preparation is to remove the undercuts, and that is not exactly preparation. I'm not giving it a proper cavity preparation form, right? I'm not giving it proper diverging walls. My only aim is to remove the undercuts because I'm going to be taking a wax impression for a cast metal post, not a prefabricated metal post, a cast metal post. It's the same technology with which your metal crown is formed, is fabricated. You take an impression with wax, you invest it, right? You take it to your casting machine. You first of all obviously burn out the wax, then take it to your casting machine and do casting with your cast metal, with your metal. And what you get is a custom cast post and core. Right, guys? So the answer is answer number C. No preparation and custom post. All right, guys. So I hope this is clear. That's a wonderful question. Again, solved only from your knowledge of Ingle. So obviously at your level, at the undergraduate level, I'm not going to expect you to start reading your Ingle now. So that's why I came up with this question. So treatment of choice, remaining radicular thickness is 1 mm, requiring a post and core, guys. No preparation and a custom cast post and core. C is the correct answer, right, guys? This brings me to the next important question, which is again a very controversial question regarding post-endodontic restorations. After endodontic treatment of a mandibular first premolar, the crown structure is sufficiently intact. Your choice of restoration would be. Now here, there is a major discrepancy what Grossman recommends and what Cohen recommends. Now guys, listen to this very carefully. Grossman simply says that in all posterior teeth, and posterior teeth are premolars and molars. All right? Posterior teeth are premolars and molars. Now Grossman says that because we are dealing with an endodontically treated posterior tooth, you have to go for cuspal coverage restoration, even if your cavity prep has been very conservative. Right, guys? Even if my cavity prep has been very conservative, I have to go with the cuspal coverage restoration. But Cohen says something else. Cohen says that if your cavity prep is conservative, go for an intracoronal restoration. What is an intracoronal restoration? Intracoronal restoration is simple. Is the fact that you can go for a direct composite or a ceramic or a composite inlay and not an onlay, which covers the cusps. Now here is the problem. What do you follow? You have to know both and you have to follow either, and your following would depend on what the options are given. See, look at the options here: metal ceramic crown, all metal crown, all ceramic crown, no crown, just restore the access with ceramic. What he basically means is restore the access with a ceramic inlay, right? Now see guys, when I'm talking of concepts, I don't care whether it's a metal ceramic crown or an all metal crown or an all ceramic crown. So for me, all three options mean the same. That is a full crown, which is a cuspal coverage restoration. I cannot choose either of the three, right? That means for me, either all three are correct or all three are wrong, right? All three cannot be correct because I don't have an option, right? So that means this question is fabricated, is constructed keeping in mind that you're going to follow Cohen. Now here, that's the catch. The crown structure is sufficiently intact, and Cohen says that if a cavity prep is conservative, meaning your tooth structure is sufficiently intact, you will go for a conservative approach and not a cuspal coverage approach. So no crown. The answer is no crown. Restore the access with an intracoronal, direct restoration or an indirect ceramic or composite inlay. Right, guys? That's again a very tricky question. You just have to basically know the protocols, and you have to know, based on the options, both on the question and the options, which protocol to fit in here, right? So this is the Cohen protocol that we're following in this question, right, guys? Which technique causes least apical blockade or clogging? So in 1985, Rohn et al. Came with the balanced force technique. Balanced force technique is just a very, a very mathematical and a very, you can say a very technical, you can say technical way of doing watch winding, right? So what do you do in balanced force? So first of all, the answer is balanced force. That's one, right? So it called the when it was introduced in 1985, Rohn and his co-workers said that, guys, you use a balanced force technique. It's the best technique in terms of causing the least errors. The least errors, whether it's, canal transportation, sledging, stresses on the file, blockaging of the canal, so on and so forth. All right. So that's one thing. So in balanced force, guys, what do we have? Always remember, there's an image-based question that can come. So in balanced force technique, the first movement is 90-degree clockwise, right? 90-degree clockwise. Then the second movement is the file. So if this is this is the first position, starting position. This is the second position, right? Now we are starting with the second position. Then the movement is 180 to 270 degrees anti-clockwise, right? So this is my third position. All right. So 180 to 270 degrees anti-clockwise. Then what happens in a balanced force? Then again, you go back to the first step. That's 90-degree clockwise, right? So this becomes my fourth position of the file. So I started with the first position, made a clockwise turn by 90 degrees. Then I made an anti-clockwise turn by 180 to 270 degrees. Then I again made a clockwise turn, which is the same as the first movement, right? And then I repeat this 2 to 3 times, right? I repeat this 2 to 3 times, and then finally I take out my file by sustained clockwise motion, continuously clockwise motion. By continuously giving the file a clockwise motion, I take out my file. Now the image-based question that comes with the balanced force technique is this. These are the same things that we've just discussed. Clockwise, 90 degree, 180 to 270, anti-clockwise, again 90 degree clockwise, and then sustained clockwise to retrieve the file. Then guys, there is another question. If there is a possibility of ledge formation due to dentinal debris in the canal, how much bend should be given to a size 8 to 10 file to negotiate? First of all, what is the ledge? Ledge is a, it's a transportation. It's an iatrogenic error which happens on the outer curvature of the canal, right? So guys, what basically happens is that if I am to instrument my root canal short of length, right? So if, for instance, this is the correct, this is an entire, this is an image-based question which is of apical zipping. Apical zipping and ledging is technically the same, but for one difference. And what is that one difference? When you create an apical zip, you basically tear open the apical foramen because you're not short of the working length. Your working length is correct, right? But you have over instrumented. What happens in a ledge is that your working length determination was wrong, guys. You were working, if the working length was 20 mm, you were working at 17 mm, right here. And then you went on digging the outer curvature of the canal and created a step here. That is a ledge, right? Now, if I have to bypass this ledge, I have to, the last 3 mm of my file, I have to give a 45-degree bend towards the curvature of the normal root canal. And then, keep on poking it. When I get a catch, I slightly put my file down inside the canal, follow the curvature, and without completely retracting the file out of the canal, I bypass the ledge. That's the technique, right? So that's the ledge that I've shown with the red mark. If you're over instrumenting, like if you're doing overzealous instrumentation, but you're not short of your working length, then you end up doing a teardrop kind of a perforation of the apical foramen. You basically kind of tear it, and that's known as apical transportation or apical zipping, right? And transportation of the canal short of the working length on the outer curvature is ledge, right? And if you keep doing it, if you don't timely bypass the ledge, and if you keep doing it, you end up perforating your outer curvature, external surface of the root, and that is known as ledge with perforation. So you have apical zipping, you have ledge with perforation, right, guys? Then there is a very interesting question from your obturation chapter. In case of acute apical periodontitis, what is done in obturation? See, irrespective of whether it's an acute apical periodontitis, whether it's a vital case, whether it's a, whether there was no apical periodontitis, ideally, the radiographic criteria is that you should be within 2 mm of the apex. So in general, they say that there are 4 things which determine the prognosis of a root canal. One is the presence or absence of pre-existing apical periodontitis, right? So obviously, if there is no tenderness on percussion, there is no apical periodontitis before you start the root canal, the prognosis is better. That's one. Second, in your x-ray, when you see your obturation, voids should not be present, right? It basically implies that your technique was correct, your obturation technique was correct. Third, you were within, now that's the point here, you were within 2 mm of your apex, right? And fourth is good coronal seal, meaning good post-endodontic core build-up, good restoration, right? So these are the 4 factors. Just write this down for you guys. So please memorize this because this can be asked in the examination. So the four factors which determine the prognosis of the root canal treatment, or once you evaluate the root canal treatment, you see the obturation. First is presence or absence of apical periodontitis. Second, all right, second, presence or absence of voids in your obturation. Then whether you are within 2 mm of the apex. And fourth, the presence of the quality of your coronal seal. So you will have MCQs in various permutations and combinations coming from these 4 points. You have to memorize these. Right, guys? So I hope this short session added value to your knowledge. I tried to, kind of take up the, controversial things so that in a short span of time, we could make this session more and more, adding up to your knowledge and information, and in improving your strike rate of getting your controversial questions correct. Right, guys? Thank you, and I'll see you with our other, with more sessions coming up. Thank you, guys.